back. And long time no see. So Prader-Willi syndrome, as we talked about, it's a model system for several important things. One is the genomic imprinting, epigenetics. A number of diseases have an epigenetic basis, and Angelman and Prader-Willi remain the best model system. But today we're going to talk about obesity and nutrition, and it's also a great model to understand appetite regulation, satiety, obesity. We're typically, as we mentioned, diagnosing these individuals as young infants, neonates, and so we can prospectively follow the increase in appetite and obesity. So obesity and Prader-Willi syndrome. Before I talk about the complications, I have to talk about how did we get there first. So this is a growth curve, and it's on the Center for Disease Control US, and you can see the top graph is the length in blue, and the bottom one is the weight, 0 to 36 months in red. And you can see this individual that I actually diagnosed at about a day of age, but unfortunately they lived in a rural area and weren't the greatest at following our advice. But you can see initially we have an NG tube in, and it was in for about 3 months, and then we took it out, and there was this period of the weight dropping off. And it was very interesting that some of my neonates, I have to give more than typical calories to get them on the growth curve. You know, if we're shooting for 110 to 120 kcals per kilo per day, we may need more in some individuals. And of course, you know, we were monitoring the food intake. We knew what this child was getting, but still was falling off the growth curve. And then at about 27 months of age, you can see the weight going up precipitously. And so we would like to blunt that, but this is another individual. In some, if again, the family situation is not the best, the weight continues to go up. And this is another individual who's a single mother who was into alcohol and other things, drugs, and wasn't taking good care of this child. And you can see her weight going up dramatically, particularly after about 4.5, 5 years of age, until she finally came into our care at the top red one. So Prader-Willi syndrome, typically, and still a lot in the literature, the traditional thinking is there's 2 phases in Prader-Willi syndrome. The first phase is hypotonia, poor feeding, frequently failure to thrive as a neonate. And then phase 2 is hyperphagia leading to obesity, beginning somewhere between 1 and 6 years of age, typically 2 to 4. And this is incorrect, the hyperphagia leading to obesity. So in the 1989, I came to University of Florida and became very interested in following a cohort of patients. I had a nutritionist with us, and Helen McCune. We noticed that that was much more complicated than the traditional 2 phases of Prader-Willi. And we started working out the various phases, and then Jennifer Miller, an endocrinologist, many of you know, joined me in 2000, 2001 to do a fellowship, and we further refined this. And then we put it as part of our NIH-funded multi-center natural history study, which began in the early 2000s and ran for 12 years. And we put it across at the other 3 sites, Kansas, Vanderbilt, and California. And so this is what we've come up with, and we published this back in 2011. And so really there's 7 phases, and this has been pretty well accepted in the field. I was a little bit fearful people wouldn't accept this, but this has pretty much been embraced by the aficionados, the experts in the field. The first phase, we knew the decreased fetal movements in most individuals, and particularly informative in our natural history study is we bring in families for 2 days, an overnight study in our clinical research center, and we'd ask them to bring in one of the typically developing siblings so we could form a control group where we comparing these individuals to. So in the first phase, decreased fetal movement, but the birth weight is about 15% less. The body mass index is about 15% less than the siblings. And so we had 79 Prader-Willis and 85 siblings that we had good birth data on. And so the average birth weight for a full-term baby was 3.0 kilos with Prader-Willi, and the SIBs were 3.4 kilos, which fits in with the typical population in the U.S. at least. Then phase 1A is the phase that we all know about, the poor appetite and poor feeding. But the key component was we always knew they were poor feeders, but it's also they have a very poor appetite. They're not interested. They don't wake to cry the mother. They don't start getting excited around feeding time or don't cry to be fed. And if people weren't vigilant, these babies would starve to death. So that's phase 1A, and it typically lasts about, the median ranges here, and of course everybody's an individual, and some do things sooner, some later, but it's 0 to 9 months was that first phase. Then the second phase is no difficulty feeding, they're growing on the curve, the appetite is improved, and that lasts between 9 to 25 months. Phase 2A now is the weight starts going up without an increase in calories. And that's very dramatic, and that's a major departure from the traditional thinking, which was hyperphagia leading to obesity. But that's not true. They'll start putting on weight, becoming overweight on typical calories. They're not going and getting the food from the refrigerator. We know what they're getting. And what it is, we have to reduce the calorie intake to about 60 to 80% of the recommended daily allowance. Some more, some less, some 50%, some can go to 90. Of course, everything I'm saying is the average, but there's ranges, of course. And right about the same time we were coming up with this, finalizing it, Tony Holland's group in Cambridge found the same thing, that the weight was going up before there was an increase in calorie. The weight was going up on typical calories. And so in science, it's nice to have independent validation. Nothing is true until someone else independently shows what you found to be what they found. And then phase 2B starts at about 4.5. We found that the appetite, and we were doing this 12-year, very careful, 2-day study, bringing families in. We found that the appetite wasn't really going up till about 4.5 years of age, plus or minus, depending upon the individual. And Tony Holland in Cambridge independently found the same thing, about that same age range. Then the phase that a lot of people associate with Prader-Willi, phase 3, which is the very aggressive appetite, the lack of feeling full, lack of satiety, really began on an average of 8 years of age. And again, some were earlier, some were later, but that was the median. And then I take care of about 70 individuals that are adults in Gainesville with a residential facility, and another 10 in the Tampa Bay area. And what I noticed in closely following those, as a medical geneticist, we don't stop, when someone turns 21. We follow them prenatally till they die. So I follow the adults as well. At any rate, we found that there was a subset, not a majority, but a subset that start to lose that insatiable appetite, that lack of satiety. Not all of them. We don't have a great handle on how many, but it's about 20% or so, 10 to 20% in their 20s, 30s, or 40s. And so we've described these phases. We've also collected fasting bloods on all these individuals. And some of them have gone through multiple stages while we've cared for them. And we're trying to look at various hormonal factors to just say, what's causing these shifts? And we've made some progress, and I'll talk a little bit about that. But the nutritional phases I feel very comfortable with, and the aficionados in the field agree. So this is the first phase, hypotonic floppy, and you can see the NG feeding tube in place, and the hypogonadism. Then this girl started with an increased appetite at a young age, 2.5 years of age, and you can see she's got some skin picking already going on in the old G-tube site. And then the phase 3, the obesity, and So what are the factors that contribute to obesity and Prader-Willi syndrome? Well, one is the hyperphagia that we've heard several people talk about, the involvement of the hypothalamus, strong drive to eat, but it's also a lack of satiety, and frequently food seeking, variable intensity, and it's present regardless of the weight or the food access. You know, a lot of days now, the families manage the children very well, and the food is locked up or restricted, and so they're doing well their normal weight, but they still have that drive, and I'll talk more about that. That needs to be closely monitored, and we're seeking treatments for it. They also, it's very clear to me that they have a decreased caloric requirement, and I think part of that decreased energy expenditure is due to decreased muscle mass. But I think that it's something more. I think they're much more efficient at storing calories and making fat than other individuals. And then the high vomiting threshold and high pain threshold, they can gorge without discomfort that most people have. And the other thing we've seen is this is a young girl who first came to us at 6 months of age, and a very nice family, very sophisticated. But they had been seeing their pediatrician, and they had a G-tube, and it was easy, and the pediatrician was shooting for a weight for length of 50th percentile. Well, at a weight for length of 50th percentile in Prader-Willi syndrome, you really look like you're 95th. I asked a bunch of our dietitians, what weight for length do you think this child is? And they said 95th percentile, including Helen, who had been with me for 10, 15 years. But we like to keep the weight for length down during this period of they don't have an increased appetite, and because they make fat cells much more easily. And you can see Parker slimmed off once they came under our care, and she's doing great. So the brain control of appetite and satiety, it's regulated by signals to and from the brain, primarily from the gut and the adipose tissue. And there's probably a disconnect in Prader-Willi, this feedback from the gut and the adipose to the brain to the hypothalamus. So this is two graphs, one showing that the body fat is elevated in Prader-Willi infants, but the weight for length is less than the control siblings. So on the left, you can see the body fat, 0 to 2 years of age. The pink is the Prader-Willi individual, and the body fat was a bit of a range, but about 20th percentile. And the siblings were a little bit less than that, maybe 18th, 17th, 18th percentile. But when we looked at the weight for length, siblings versus Prader-Willi individuals, the Prader-Willis had a weight for length about 26th percentile, whereas the siblings had a much higher weight for length, about a little bit over 50th percentile. So the siblings had a higher weight for length, but less body fat as measured by DEXA. And then the BMI Z-score, in this US, that the BMI Z-score start at 2 years of age. So phase 1A, we were 26th percentile weight for length, then we switched to BMI. And you can see phase 1B is much below the BMI 0 curve, so in the minus standard deviation. But 2A, it pops up. That's when the weight starts to increase without calories, or increase in appetite and calories. Then phase 2B, the appetite's going up. Phase 3, that's the typical insatiable lack of satiety phase. In phase 4, we only had a few individuals, but their BMI is a little bit lower. So I don't have time to go through all the data in this short amount of time, but we've been intensively looking at this for close to 15, 20 years, and and I'm just going to summarize our observations. The transition to phase 2A coincides with the onset of hyperinsulinemia in Prader-Willi syndrome. The transition to phase 2B with the increase in appetite is associated with the leptin going up significantly in Prader-Willi syndrome. The fasting glucose levels stay pretty much the same, even when the insulin and the leptin are going up. It's regulating, and the glucose is still at homeostasis. The hyperinsulinemia and the hyperleptinemia coincide with weight gain and hyperphagia, respectively, in Prader-Willi syndrome. And we also looked at ghrelin. I've got great curves, and we published this. But the ghrelin was shown years ago to be up in Prader-Willi syndrome. So we and Matej Tober and others looked across the age span. The initial report was children. Well, we went down to the neonates, and we found that ghrelin, which is a appetite-stimulating hormone, orexigenic, is the highest when they're neonates. So when they don't have an appetite, have a lack of appetite. So our feeling at this point, and there's various other pieces of data, we don't think ghrelin's going to be a big player in driving the appetite. There's a caveat, though. But we think it's involved in the increased body fat in Prader-Willi syndrome, but not necessarily the hyperphagia. Now, after we had accumulated our samples and we put them all in aprotein, a protease inhibitor, and froze the samples, it came out that there's two forms of ghrelin, acylated and unacylated. And the acylated seems to be the active form, and the unacylated maybe retards the appetite. Unfortunately, we didn't collect our blood samples in AEBSF, and that's a preservative that you need to distinguish the two types of ghrelin. But we have other data, and there's some trials going on now with an inhibitor for unacylated ghrelin to acylated, and then another study in France that's giving unacylated ghrelin to try to reduce the appetite. Remember, acylated is the active form. My feeling still stays the same. We've been doing one of the clinical trials, and I still don't think ghrelin's going to be the big driver of the appetite in Prader-Willi syndrome. And the clinical trials will play out, but I think that's going to be the answer. So what's responsible for the hyperinsulinemia in Prader-Willi syndrome? Going back, and Professor Witter talked about the hypothalamus and hypothalamic dysfunction. We think that results in central, not peripheral, central insulin resistance, which is the trigger for the hyperinsulinemia. We still have a lot of work to do on that, and unfortunately, I can't show you all the data at this point. So what are the medical consequences of the hyperphagia and obesity? Well, there's cardiopulmonary compromise, and the effect is seen even after there's been a weight loss. If someone's been significantly obese, an adult, they come into our residential facility where they all lose weight in a controlled fashion, they still have had damage to the cardiac pulmonary system. And we've had a couple of individuals that died in right-sided heart failure, even at a normal weight. And so I think the consequences of being overweight for many years, coming into our facility, you lose the weight, but you still have had the damage. It's kind of like being a smoker for 20, 30 years, and you quit, but there's still the damage that's been done. And I've seen that firsthand, too, in autopsies on smokers. Type 2 diabetes is pretty frequent in the obese individuals with Prader-Willi syndrome, but most resolve after the weight loss. So they come into the residential facility, we're able to take them off insulin if they're on insulin, metformin, etc. Obstructive sleep apnea is a problem, of course, with the weight and compressing the airway. And several of us have talked about the need for sleep studies, individuals with Prader-Willi. Peripheral edema, skin breakdown, deep venous thrombosis leading to pulmonary emboli. These are all problems. And also, there's a lack of energy. When our persons with Prader-Willi come into the group home, they lose the weight, they start to have more energy. Now, of course, if you're giving them growth hormone, that helps too as an adult, as others have discussed. Hernias are more likely. And the other big thing is we can lose the weight. They come into our facility, but if they came at 300 pounds and we get them down to 120 pounds, they're left with stretched skin and a lot of loose skin as a result. And here's an individual. You can see the very large legs and the sores, the breakdown of skin on those legs, and the poor circulation. A lot of them get cellulitis, infection of the skin. That can become bacteremic or septicemic. So you need to be on top of that. And the other thing is we want all our individuals in the residential facility exercising every day. They exercise more than I do, which is not very proud of. But they have to do 30 to 60 minutes of exercise every day. And I like the walking is very important to keep that blood flow going, because the circulation to the feet is in all of us is pretty poor, particularly if you have a lack of muscle mass. And we've had individuals that I'm sure some of you know about that have deep venous thrombosis leading to pulmonary emboli and that have died. And a couple died in the Zafgen study, which that initial first generation drug exacerbated the clotting in Prader-Willi. And then the abdominal hernia in this individual, you can see her legs are bandaged. And then you can see the hanging skin after the weight loss. She's lost a lot of weight. She actually has a very interesting imprinting defect. And you can see across her abdomen she had surgery to fix the hernia. But there's still this hanging skin and the discoloration of the legs from the poor circulation, the cellulitis, the infections. And then, we had the individual on the left came in and had very large legs, probably lymphedema as well. We've lost the weight on her, but she's left with that hanging skin. So GI problems, choking due to gorging, especially hot dogs are very problematic in people that if they gorge. Dr. Stevenson documented this was the cause, 5 to 10% of causes of death in Prader-Willi. So gastric dilatation, necrosis, ruptured, first put forth by Wharton, who first noticed this in the 90s, and then Roger Stevenson has followed up on this being a factor, an area of concern for individuals with Prader-Willi. And interestingly, often this is in individuals that had been obese, they became normal weight, but then they got into a lot of food and got into trouble with gastric dilatation and necrosis. There's gastroparesis, slow GI movement, gastric emptying. I think one of the other speakers is going to talk more about that later. And constipation, predisposing individuals to have this gastric dilatation leading to necrosis, and in a number of cases, death. And I remember I had a child about 10 years ago that over Christmas he was very lean and he got into a lot of food and it became problematic. And I'll talk more about that. And this is 2 adult patients I recently had that happened to be on a high roughage, high fiber diet, which at first blush you think is probably good. It'll help them, make them feel full being on a high roughage and fiber diet. Roughage is like salads, the skin of apples, etc. But in Prader-Willi, the feedback is broken. That feeling of feeling full, there's a disconnect frequently between the stomach and the brain, we think. And so, our clinical and scientific advisory board recently met in Munich, and we don't think, and this may be a bit controversial with some people here, we don't think a high roughage, high fiber diet is good, particularly for the adults, because it'll slow their gastric emptying even more. And this individual, you can see on the left, on a plain film, the dilated stomach there. Let's see if I can point that out without advancing. So here's the dilated stomach. And then here on an abdominal CT is, again, the filled stomach with a lot of undigested material, that whole black area across the abdomen. So we've cut back on the amount of roughage and fiber. I mean, some is okay, but really pushing it, I think, is not a good idea, particularly in the adults. And this is the individual I was talking about about 10 years ago around Christmas time. The family had done a great job with him. And Jeremy was in really good control. He was on growth hormone. Then Christmas happened, and the family had a big buffet dinner, and everybody thought everybody else was watching Jeremy, and it turned out nobody was watching Jeremy. And he gorged on a lot of food. Of course, he ate it quickly. He didn't chew it well, and it sat in his stomach. And so he showed up in Orlando at one of the major medical centers down there, which is 2 hours south of us. And the family called me up. I talked to the ER doc. They they didn't think he looked that sick. He wasn't in a lot of pain. He wasn't vomiting. And they were going to discharge him. And I said, you better not discharge that patient. You better empty that stomach, and you better admit that patient. And very reluctantly they did. We're the major medical school in Florida, so they listened to me, fortunately. They admitted him, and things went downhill. The surgeon operated, and by the time he operated, just everything had necrosed in the abdomen. So the point is, if you look at Jeremy, he looks great. He's nice and lean, but the appetite drive is still there, and the supervision has to be constant, 365 days of the year, 24/7. It's not 364 out of 365. And the family's become very active in the U.S. PWSA. So treatment of hyperphagia and obesity, currently there's no effective pharmacological treatment. Several drugs are under clinical trials. Now we have a bunch of clinical trials going on in the States. Bariatric surgery is a bit controversial. I think Professor Wittert said that they've done some Roux-en-Y down in Adelaide. But with the standard methods in the past, there were high rates of complication, low rate of long-term weight loss, and Ann Scheinman has summarized this. There's some newer techniques, the sleeve gastrectomy, the mini gastric bypass, but there's been no good clinical trials or long-term studies yet. I know there's a group in Mexico that has done 5 or 6 individuals, but Morris Angulo was recently down there, and they were still pretty obese. So I think a lot more needs to be studied here. And again, at least the current thinking, at least my current thinking, is there's a disconnect between what's going on in the gut and what's going on in the brain. So if you make the stomach smaller and they get into a lot of food, you're increasing the risk of gastric necrosis and rupture. But again, you have to do the studies, you have to have good controls. And then some people are trying transcranial direct current stimulation, and it may have some benefit. Tony Holland's doing some work too with the vagal stimulator. So what's the prevention management currently of obesity in persons with Prader-Willi? A very low-calorie diet. So my 70 individuals in Gainesville and 10 in Tampa, we have them on caloric allotments of about 1,000 to 1,600, and it's variable. You can't put them all on 800. A lot of places stick them all on 800. Some can take more, some can take less. And if they can take a bit more if they're on growth hormone, but again, it's not a diet pill. It just helps increase the muscle mass and caloric utilization. Lots of physical activity and exercise, and then food security is very, very important. Even if they're lean and trim like Jeremy, they still have the appetite drive. So everybody needs to be educated, from the parents to the grandparents to the siblings to the school. And then early diagnosis, I think, is a very key component of preventing obesity. Robust tests that were developed in the 90s, and my lab was part of that, lead to earlier diagnosis and treatment, increased awareness through groups like this and advocacy. And now we're diagnosing the vast majority of our kids less than 2 months of age. I mean, I just got a call from our NICU that there's another one at our hospital. So our neonatologists are really attuned to getting the geneticists up there. And then doing the guidance and counseling and tell them what to expect. Initially, there's a poor appetite. Yeah, there's failure to thrive. And then if you don't know the diagnosis and people start putting on weight, everybody's really happy. But if it's Prader-Willi, it's going to keep going up. So that's an issue. So knowing what to expect, I think, is key to treatment. And these curves just show from our natural history study of 355 individuals that the age of diagnosis makes a big difference in terms of when the onset of obesity. And the lower curve in blue is they were diagnosed at less than 1 year of age. The one in red is 1 to 3, and then the top one is 3 or higher. And you can see the blue curve, the probability on the y-axis is really lowered in terms of age first becoming obese. So the earlier the diagnosis, the later that people become obese, and some don't even at the end, that you can see at 20, is a significant subset that haven't become obese. So final thoughts, obesity comes with many life-threatening complications. Some are correctable, some aren't so correctable. Early diagnosis and appropriate counseling are key. Behavior modification helps. Prader-Willi specific residential facilities for adults is very effective versus non-Prader-Willi specific residential facility. And I think the future looks bright. We're doing a bunch of clinical trials. I've been in this field long enough to know, we were coming out of the darkness. The genetics is getting really good, and some of these clinical trials will really be efficacious. And then this is Justice, who's one of our children we follow, who's 15 years of age, and could pass as a model, in my opinion. So I'll open it up. I think I have a few minutes for questions and comments.
Yep.
Yes?
I have a double question. It's about Jeremy's necrosis. I mean, I think everybody's a bit shocked that a kid this thin can just die of a one-time gorging. So can you, for the layman, can you explain exactly what is the necrosis, and is there any external signs that we can look out for?
Yeah, that's a good question. So he, the gentleman up front was kind of shocked by the picture of Jeremy, my 16-year-old that died of gastric necrosis, because he looked so trim and healthy, and that just one episode of binge eating could lead to gastric necrosis and death. And what is gastric necrosis? So it turns out there's one detriment to being thinner versus obese. Your stomach is not quite as big, and what you're used to taking in a volume is not quite. But the appetite drive is there. And so a lot of times these gorging episodes, and we have several, it turns out that people that have been obese, they lost the weight, they're more at risk for this gastric necrosis, it appears, than those that are obese and never got them. At any rate, they get into a lot of food, they don't chew it adequately because they're doing it surreptitiously. And what happens is the stomach expands. And when the stomach expands, the gastric wall thins. And when it thins, then the vasculature, the blood that's able to go in there, isn't fully oxygenating, penetrating the gastric mucosa. And so you get necrosis, the cell death, tissue death. And then if the stomach has a hole in it, it bursts, that acidic contents gets in the abdomen, and then it's just necrosis. I mean, the surgeon almost passed out when he opened the abdomen. And he was a pretty cocky surgeon, by the way. So it took a lot to impress him.
Is there any external sign?
Oh, external signs. So if there's any vomiting, and I neglected to mention, he vomited at home. He didn't vomit in the hospital. So if an individual with Prader-Willi vomits, that's a really important sign, a warning sign. Unless everybody's got gastric flu and everybody else is vomiting, but even still it should be checked out. You should have a low threshold to check out a person with Prader-Willi that's vomiting. They also don't have much pain. Jeremy wasn't in much pain, so that's why the ER docs weren't that impressed with him. And they have slow gastric emptying. So they took a lot, it's undigested, big chunks sitting there, it's not getting out of the stomach, and they're not vomiting it either. And so it sits there and it swells up like a balloon, and if you blow up a balloon too much, it bursts.
Oh, yes.
Yes?
Yeah.
Noli, not a parent. What was the time frame from when he ate the food to when the necrosis presented at the emergency?
Well, so I'm trying to remember. It was Christmas Eve, and they woke up the next day. I think it was Christmas, and they noticed, he had gone to bed, and then they noticed when they woke him up in the morning that he had vomited, and so then they weren't quite. They had dropped out of being active in PWSA, so they hadn't heard. PWSA USA is good about it, spreading the gastric necrosis that Bob Wharton had alerted us to, but they hadn't gotten that message, so to speak. At any rate, they called up a few people, another family. That family called me up, and so they went into the ER that morning, and then they were in the ER all of Christmas, and then they went to the OR that night. So it was like 24, 36 hours before he died on the operating room table. or shortly after that.
Oh,
Sorry.
you go ahead. Yeah, we'll take these last two and then we've got to.
Thank you, Dan.
Hey,
Very interesting about the necrosis and gastric emptying. With respect to when you get to the next stage, the colon and the high fiber diets, if a lot of our people have severe problems with constipation, and also if they've had a high fiber and then high exercise, they can deal with it. But once the exercise falls away, do we sort of end up in a similar situation with stretched colons that might cause? We've got a lot of, actually more than we know of, colon resection
Right.
and ectomy and so on.
Yes, so it isn't just the stomach. I've had one individual that had volvulus that was on a high roughage, high fiber diet, an adult, that had to have an operation. Both those patients survived. So it isn't just the stomach, it's the colon too. And there's, I know a lot of people are thinking, okay, roughage and fiber for the constipation, but there's other ways to treat constipation. And we have to realize, and there's a speaker later that's going to be talking about gastric emptying and GI motility, but it's compromised in Prader-Willi syndrome. And so giving it a lot of roughage and fiber compromises it even more.
Professor Campbell?
Yes, we do a simple pictorial questionnaire in our studies, which other people in the world use now, which says, with pictures, how full does your belly feel? Small, big, and big. And then, how much more could you eat on a plate? And again, so very cognitively simple, but pictorial. And the interesting thing that Prader-Willi subjects do is they say, how full does your belly feel? Right down the big, but how much more could you eat? And it's the plate. And this differs from others, and we compare them to obese and to non-obese. So to me, it's that point. It's not the full, something, there's a disconnect between the fullness, they're aware of fullness, but they can eat more, and that's the danger. That's where what you're describing is, but what is the cause of that?
Yeah, and that's a good point. The other thing, we've done some of the questionnaires, and sometimes they're a bit biased. They know what the right answer is supposed to be. And, particularly those that have been around. So
Ours
we always
don't
have trouble
necessarily.
sorting that out. But,
There's a disconnect. They admit, this full, how much more can we eat?
yeah.
And that's been told to be obese.
We have to see what they say they are in the morning before they've eaten. Do they say they've got a small stomach? Have we looked at that?
That we haven't, but these are the meal
We'd
studies.
have to do that.
Yeah, there's got to be some sort of
Be
control.
interesting to do that.
Yeah, it's a good point.
Okay, we better move on.